Welcome back. We're going to continue in the digestive system. We're going to start our tour. So we're going to start in the mouth and work our way down the esophagus here. Again, best comics in the whole semester in the digestive system. Take a look at them. All right, so the mouth is our oral cavity, also called the buccal cavity. We have all of the boundaries. We know we have stratified squamous epithelium there. So we've got some muscles that are going to, kind of control the movements here, so muscles that we've seen before. The palate is going to consist of the hard palate and the soft palate. So the hard palate we have learned about, you know that it's the maxilla and palatine bones. And then as you continue posterior, the soft palate is kind of a mix of muscle tissue and kind of almost like a spongy type of tissue, and it ends distally at what's called the uvula, probably more commonly known as that thing that hangs down in the back of your throat. So you know when you go and you stare in front of the mirror and you open your mouth really wide and there's that little thing hanging down, that would be the uvula. The tongue is going to take up the majority of the oral cavity when your mouth is closed. It's muscular. It's actually a remarkably strong muscle in terms of the fibers and amount of force that they can generate with the cross bridges, but it's just not really attached to anything that would allow us to do much with it. It's very sensitive. It's got a lot of receptors on it. It's usually your tongue that alerts you to the fact that there is a hair in your food or something like that. And it's also pretty agile for being as big and bulky as it is. I mean, like 99% of the time it gets out of the way of your teeth. I mean, we don't bite our tongue every single day, and so it moves around fairly well. It's basically muscle. You've got the intrinsic muscles that are basically very small, tiny muscles that work within the tongue, and then the extrinsic muscles that are attached to it that actually move the tongue around. So there we go. We have all done this before in the mirror. So, when we close our mouth, the tongue is taking up the majority of the space. Here is the palate, the uvula. The palate is really important because it creates an anatomical distinction between the nasal cavity and the oral cavity. An incomplete palate means that food and drink that goes into your mouth could be aspirated into the respiratory system, which obviously is going to be a problem. So an incomplete palate occurs when the maxilla and palatine bones do not fuse properly during fetal development. Big thing we've got going on in the mouth is obviously our taste receptors. So remember that taste is one of our chemical senses. So we have chemoreceptors in here. We dissolve our molecules in our saliva, and then we activate our different taste receptors. We've got the whole concept of sensation versus perception going on with the taste receptors. Here's a couple comics that are kind of funny. You can look at them. It's kind of like why we consistently bite our tongue in the same place. I don't know if that it's a scientific explanation, but it's kind of funny. All right, so our teeth are found in the sockets in both the maxilla and mandible. Those are joints. If you remember from 251, it's a gomphosis type of joint. They function in mastication or chewing. Humans have 20 deciduous teeth, which are your baby teeth, and then 32 adult teeth, and we have 4 different types of teeth. So we have incisors, the sort of middle 4 teeth that are kind of sharp, canines that kind of almost are pointed to really tear into something. And then we have premolars and then molars, and these are more flat to grind things. You can see that we tend to grow them from the front back. So we tend to lose our front baby teeth first and then replace them with our adult baby teeth. And you can see that you have almost all of your teeth by, you're 12-ish years old. Here we can kind of see where the adult teeth lie. They are actually in the bone above and below the baby teeth. And so it is the pushing up of these adult teeth, the ones with the stars on them, that forces the baby teeth out. So you have all of this completed by roughly about 12 years old, except for this last set way back here. Those are your wisdom teeth. They are going to erupt much later, so somewhere in your late teens to early 20s, if they come through at all. A lot of times we don't have enough space in our jaw for these. We have seen some changes to the jaw over human evolution that has kind of created a little bit of a cramped space. If you combine that, slight change in the size of the jaw with better dental hygiene, we've got a slightly smaller jaw, but we're also keeping our teeth much longer than we did before. If we think about early humans, they had a lifespan of, maybe 40 years. So, not taking care of their teeth very well, in all likelihood by, age 21, halfway through their life, they would have lost some teeth. And that would have created a little bit more space for this set of chewing teeth to show up about halfway through the lifespan there. So we tend to keep our teeth longer, and we've got a slightly smaller jaw, and so it creates this bit of a problem with a lot of people's wisdom teeth, and then they're incapable of erupting properly and oftentimes have to be removed. All right, the salivary glands are our first accessory organ. We've got intrinsic and extrinsic glands. The intrinsic are just constantly secreting. The extrinsic are where you get the majority of the saliva. So we have the parotid glands that sit right here in front of your ear. They are the largest. Then we have the submandibular under the mandible. These produce the majority of the saliva. And then the very small sublingual under the tongue. So these are a combination of serous and mucus cells. So the serous cells are going to secrete kind of a watery component, whereas the mucus cells are going to give us that thicker mucin protein that's going to make mucus. Together, you get good functioning digestive saliva. So it's definitely mostly water. It's a little hypotonic, little bit acidic. It's got a lot of electrolytes in it, so we tend to see like sodium and potassium, things like that. We have two enzymes in saliva, so we have salivary amylase and lingual lipase. The salivary amylase works at the pH of our mouth, and so it will start to begin the breakdown of starch in the mouth. Lingual lipase is secreted into the oral cavity, but it works at a pH of about 2. So you swallow the lingual lipase into the stomach where it becomes activated, and it's going to mix with gastric lipases, and we begin the breakdown of lipids with those. We do have some immune properties here. So remember our secretory IgA. We also have lysozyme, which is kind of just a generic antimicrobial enzyme. And then, of course, we have mucin. So mucin is the protein that is going to make mucus. We're going to secrete somewhere in the neighborhood of about 1.5 liters of saliva a day. Most of it, the majority of it, comes in response to eating. So as we begin to eat, our receptors are going to tell our salivary glands to begin to secrete and kind of contract and push the saliva into the oral cavity. If you've ever put something real kind of almost sour in your mouth, you may have had the feeling where you could actually feel kind of almost like a contraction right in front of your ears. That's your parotid salivary glands kind of squeezing to try to get saliva into your mouth. Those are usually the ones that we can sometimes feel do this. We're then going to move into the pharynx. So we've kind of talked about a little bit of the pharynx in the respiratory system. So the oropharynx and laryngopharynx are going to be part of the digestive system as well. We've got our stratified squamous epithelium for protection from the swallowing. We got a lot of mucus glands, and we're basically a bunch of skeletal muscles. Pharynx is then going to lead into the esophagus. So the esophagus is basically just a tube that runs fairly straight down the mediastinum and is going to pass through the diaphragm muscle at the hiatus. So there's basically three things that pass through the diaphragm there. You've got the esophagus going down, you've got the aorta going down, and you've got the inferior vena cava coming up. So all of those are passing through this kind of connective tissue-filled opening in the diaphragm muscle. The esophagus is then going to join up with the stomach at what's called the cardia, and we're going to find the lower esophageal sphincter at that point. So we know the relationship here between the esophagus and the trachea. So we know the trachea runs anterior and the esophagus is behind it. And here's your little epiglottis. And so we know what the job of the epiglottis is because we talked about it in the respiratory system. It's to close off the trachea so that when we're swallowing something, it goes into the esophagus and not into the trachea. So I don't think this is how it actually works, but it's kind of hilarious. In terms of the muscles in the esophagus, it's kind of an interesting makeup. We've got the upper 1/3 is purely skeletal muscle. The lower 1/3 is purely smooth muscle. And then the middle 1/3 is a mix. So you have both skeletal and smooth muscle there. If you look at it in histology, you actually see the two different types of muscle cells sitting right next to each other, which is actually it's very interesting. We don't tend to see that anywhere else in the body. We also have a lot of mucus glands because we want whatever we're swallowing to be kind of really well covered in all of that mucus so that it goes down very smoothly. We've all had the experience of not having chewed everything up and swallowing something and it kind of pushes its way down and it's sort of uncomfortable. That's not what we want to happen. Last thing here would be the concept of swallowing. Its fancy name is deglutition. So we have a few things that are going to happen when you're swallowing. So you put something in your mouth and you're getting ready to swallow. And basically what we're going to do is we're going to physically block off every possible avenue for this bolus of food or drink to go except the esophagus. We're going to basically put up roadblocks everywhere. So when you go to swallow, you're going to push everything up to the top of your mouth. So you're pushing it up against the palate, and that's going to have the effect of sort of pushing this soft palate, and it's going to start a reflex that's going to occur. The distal end of the palate, the uvula, is going to flip up, and it's going to close off the nasal cavity so that this can't move up that way. The tongue is going to be touching the palate, so that's going to make sure that it can't come back anterior. And then the epiglottis is going to flip down, and it's going to cover up the trachea. So we essentially cover all spaces that this could go into except the esophagus. And so that is going to allow this to move into the esophagus, and then we're going to start peristalsis, and we're going to squeeze, pull, squeeze, pull, squeeze, pull, all the way down into the stomach. The lower esophageal sphincter will open, and we will move into the stomach, and this wave of contraction will come right down with it, and that sphincter will close very tightly after it's